Okay, in that case, I'm going to hand over to the physios who obviously practice more clinical medicine than anybody else and are always working with their hands. So, and they'll talk us through the examination and also the management of hamstring injuries in these studies. So, you want to kick off, Nicol? First, I present Nicol Van Dyk.
Good afternoon, everyone, and thank you for the invitation to be part of this illustrious group this afternoon. So Philip and I will present to you our hamstring strain injury protocol and assessment and treatment and basically our Aspetar experience. We would also like to thank the organizing committee for allowing to share this with you today. So we'll share with you our main findings from the research we've done, looking at return to play, or I've called it return to sport, and then what could predict that. And then as Adam said, the clinical assessment seems much more valuable, so then our question becomes, what do we measure in our clinical exam? What is really useful to know? So we'll share that with you based on our daily assessment and our progression, or protocol, criteria-based regression protocol. This research we did was concurrent to a large RCT performed at Aspetar, and there are of course many contributors. Rod Whiteley you may have heard speak yesterday, and Philip presenting with me, but we'd also like to just mention our late colleague Patrice Muxat, who had a huge role to play in how this protocol came about, who passed away last year, so we also think of Patrice. And then I'd also like to mention Arnlaug Wagenstein. Arnlaug is a postgraduate researcher from Norway, and a lot of the injuries we see is based in football. So we thought we should import some handball experience, and who better than a female Norwegian handball player, or a former female Norwegian handball player? They are the current European champions. So this is what we expected, and we were not disappointed. Arnlaug has, however, exchanged the beautiful Norwegian mountains for an Aspetar uniform, and we would just like to acknowledge her contribution to where we are today as well. So let's set the scene. As Marcus showed yesterday, I think he said he's never seen a hamstring strain injury in his involvement with his team, but I think it is still an important injury to be able to manage. So imagine for a moment a handball player, 24-year-old Abdallah. He came to us at the end of last year. The Qatar World Championships is being held in 3 weeks' time, and he had a hamstring strain injury 1 day ago. MRI confirmed grade 2 biceps femoris. So how many of you think, well now I guess Bruce and Adam has given some of the data away, but think he'll be back to playing in 10 days? 20 days? Right, only Rod, that's biased. 40 days, right? So hold on to whatever number you have in your head, and we'll show you what we found. Because in the literature, even though hamstring strain injuries have similar gradings and the sports have similar requirements, the variance is quite wide in terms of how long it does take to get back, from 1 week to more than 50 weeks. So indeed, if we can predict your return to play, what do we measure? And this is the essence of what we want to share with you today. Which measures in our clinical assessment is valuable? Because this is the question we now get faced with by our athlete, our coaches, and the management. And we wanted to be able to give them a better answer. So this was our plan, an assessment protocol, a treatment protocol, and we looked at grade 1 and 2 injuries. So as Adam mentioned, there is some evidence for the grade 0s and the more severe injuries, but the crux of what we see happens in grade 1 and 2, and we wanted to be able to determine that answer. So we have an initial assessment, a daily assessment, a treatment protocol, and then we agreed on discharge criteria. I'd just like to mention everything we say is in a handout that you should have. There's some at the back, I believe, still available. So you can go through that again, and it'll all be summarized in there. I haven't referenced anybody in the handout, so if you run into Carl Askling, please say to him, Nicol did acknowledge that he didn't reference him in the handout. So our initial assessment, well, this is, I think, fairly basic and what most of you would include in your assessment as well. I think the player in this picture might have a hard time to explain what happened exactly to his physio, but indeed we want to know a little bit of that initial history. The mechanism, of course, were you jumping, running, kicking, sprinting. We also look at pain and the pain you have today, but also the initial pain you had at the time of the injury. The past history, of course, hamstring strain injuries and anything else, lower limb, lower back, and whatever might be relevant. We measured the gait and just called it normal, painful, or if you needed help. Palpation, which we'll get into a little bit later, but we looked at the length of pain, flexibility, and we developed a specific test called the Aspetar hamstring flexibility test. In your handouts, it might be referenced as MHFAKE, which really means maximum hip flexion, active knee extension. So Philip will get into a little bit more detail about that. We had an active movement, and then we also did strength measurements with a handheld dynamometer, and we tried to standardize that as much as possible. So since we'll show you our daily assessment in a moment, I'm not going to go into too much detail, but we always also perform this initially. And our daily assessment, which is what Philip will practically demonstrate to you, looked at these 5 areas, which is, I think, what most of us would consider valuable in terms of assessment. Now, for the treatment protocol. Well, we tried to think of everything we would possibly use to treat a hamstring strain injury. And then we said, okay, let's try and organize this so that it's from the easiest to the hardest. And when we did that, it seemed like it naturally formed 3 stages. So we grouped them in 3 stages with specific criteria for progression. So it was easy for us to base this not on time and not too subjectively, but on measurements that we could take daily. And Philip is going to talk about that in a little bit more detail. Our daily assessment also helped us to reassess and compare the athletes and then decide whether he progresses in the protocol, regresses, or stays at the same level. And then we had specific discharge criteria that we agreed upon, and then recommendations that goes back out to the club, which has developed a little bit since Arlo came on board. But basically, you had to be able to perform 3 functional sport-specific sessions. You had to be able to form an isokinetic test with no large difference in strength, and we used the common 10% measurement. And none of your initial assessment tests should have any big imbalances. So, what did we find? Well, if we take Abdallah, and he got injured on the 10th of January, would he have made it, or on the 10th of December, would he have made it back in time? We think so. Think of that initial number you had. It basically took around 3 weeks. So our data based on 90 players, and I'm just going to make you focus on the top row, showed about 23 days to discharge. That included about 19 or 20 days of treatment. And also just to mention, we usually see the player on day 3, because I'll get into that a little bit. But it happens on the weekend, and then we see him the first day of the week. So then how did we analyze this data? How did we then decide which of these measurements would be important? Well, again, we took all the measurements we had that we thought could influence our prediction of return to play. And then we performed regression analysis. If you're like me, then this is how you feel. But this is an actual regression analysis equation. And I won't get into too much detail, but basically this gives us a model where we can plot in data, and that gives us a number, an actual number we can give to the player. Now, Adam just showed you what the variance is with the MRI. And we're going to do the same. Just, I think regression analysis is best summarized in this quote by Einstein, or it's commonly credited to Einstein. It was actually Bruce Cameron, not Bruce Hamilton, although I think Bruce might have said the same. And not everything that can be counted counts. So that is what we try to find out with regression. What about the things that we've counted is important? And this was our results. Our initial exam could explain 50% of the variance with a 23-day range. So again, that's clinically hard. That doesn't give us any help clinically. With the MRI, as Adam has said, that increases, that gives us 3% extra. So, and then we have the 40 days. So that still doesn't clinically help us. But when we did a week 1 equation, we could explain 97% of the variance. Now, the statistics here did get a little bit interesting, and I'm not going to show you that. I will try and explain to you in just a second, but just to mention, there is still a plus or minus 5 days. So clinically, if this is all our data with our 97% variance explained, and I predict that you'll take 20 days to go back to play. Now, I've said I can explain that much of the variance, but even with that much of the variance explained, I still have to say to you, it could be as little as 15, and it could be as much as 25. So again, clinically, does this help us? Well, we think it gives us a better answer to the patient and to the player. And these are then the measures that we think are important. And these are all the measures that got into that equation to give us a reasonable answer. So the bigger they are, the more important they are. And it's clear that strength and flexibility is in there again, pain as well, and of course, no MRI. Right, so I'm going to hand over to Philip, and he's going to take you through our protocol and daily assessments. I'll just urge you when we get to the practical part, we're quite a large group, so stay seated and you will be able to see the whole demonstration on the screen.